Take just a second to kind of let some more people filter in. But if you guys would like to let me know where you're joining from, I know we have people kind of coming from all over the world, and that would just be amazing to hear where you guys are all joining in from. Mary says she's taking her exam today. Mary, I hope that you used our product and that you feel prepared. I think you should be confident if you did. Hello, Rick. Hi. The Philippines, Pennsylvania, Ethiopia, Connecticut, Georgia, Israel. All right. People from all over. Good deal. Well, we are going to be talking about case studies today, but just a couple minutes longer while we wait for some more people to show up, I want to ask you guys who are here, on a scale of 0 to 10, how comfortable are you with ABG interpretation? And we may or may not be interpreting an ABG result today, so I don't know, it'll be a surprise, but let me know, how comfortable are you with that right now? With 0 being I'm completely lost looking at an ABG, and 10, I could do it in my sleep. 9, 7, okay. 8. Wow, you guys are all really prepared for this. Okay, I remember this being like a tough subject when I was in school for a lot of my classmates and everyone, so you guys should be able to knock it out in no time if you're this prepared with your 7 to 10. Jasmine's a 10, Iris is a 10. Rick says he already passed NGN using Bootcamp. Rick, well, thanks for coming back and letting us know, and that's why you're a 10 out of 10 prepared. Awesome. Okay, wow, well, great. Well, you guys, we've got 100 of you here, so let's go ahead and get started. So my name is Emily. I'm one of the co-creators here at NCLEX Bootcamp. We've also got Courtney in the chat, Dr. Courtney, and she's going to be answering any of the questions that you raise. I think someone asked about whether it's useful for LPN or not. And Melanie, this is going to be about 30 minutes long, and we are going to be talking about how to answer next-gen NCLEX case studies. So, yep, this is me, and we're going to talk about this in 2 parts. First, the NGN case study format, just so you know what to expect, and then 2, practicing walking through the case and thinking like a nurse. And if you've attended this webinar before, we've got a brand new case study for you today. We were doing our heart failure case before, and I won't tell you which one this is today because it's up to you guys to figure it out. So, all right, first, the NGN case study format. So this, you guys know if you've had some case study practice, is the 6 items that make up the case study, and these represent the 6 steps outlining how a nurse thinks in the clinical judgment measurement model. So you might not be familiar with this 6 steps per se, but this is going to really closely parallel the nursing process or the ADPI process that you should be familiar with. So always it's going to start with recognizing cues or assessing what's most important out of all the findings that we have for our patient. Then second, we're going to analyze those cues or kind of diagnose what they could mean. Then we prioritize where they start and generate solutions. So what can I do? This is your planning step. Then you're going to take action and actually do the thing, implement your nursing intervention. This could be giving a med, teaching, contacting the healthcare provider in some cases would be the most appropriate nursing action. Then finally, we're going to evaluate the outcomes or figure out, did it help? So these are just the 6 steps of how you think through clinical judgment. And it's really important to have these down, to have a lot of practice with these, because you guys are all going to see at least 3 full-length case studies per exam. Now, if you've had classmates tell you that they had like 5, 6 case studies on the NCLEX, that's possible, but there are only 3 scored case studies. If you get more than that, those are going to be the unscored test items. They're testing that case study on you to see if it's valid. Don't get hung up on whether you think it's a real case study or a test case study. Just answer all of them as if you're being scored on them and you will be fine. But this section of the NCLEX makes up about 25% of your score, a quarter of your score. So this is bigger than all of the other client need areas that are going to show up as standalone items. And so this is the important part to get right and to make sure that you have practice thinking like a nurse this way. And so after those 3 case studies, you might get some additional clinical judgment standalones like the bow tie items or the trend items. And those are the ones that kind of pack all of those steps into just one item. We're going to practice together thinking like a nurse. So we are going to pull up a case here in a second, but I want you guys to know for this first step, it's really important to kind of envision the scenario closely. I like to kind of keep a picture of the patient in my mind and update that picture as the case unfolds. I like to kind of read it at first before I ever look at the questions and figure out what's the priority problem. What should I kind of consider first? And then each time the case study updates, you want to revisit that mental picture, because even something as simple as moving from the ER to the ICU or the ICU to the step-down unit can affect how you would answer the item. So just kind of keep in mind this picture as we go. So we're going to read this together, and as we go, I'm going to highlight some pieces that stand out to me as being potentially really important, or things that flag in your mind as like, oh, this is important, I need to remember it later. Now, on the real NCLEX, you won't be able to highlight things like this, but you're going to have your dry erase board that you can just kind of make notes on. So it's the same thing, we're just going to highlight it so you guys can see what we're doing. So all right, we've got a 22-year-old in the emergency department. His mother calls 911 because she found him unresponsive at home, so that's not good. Then he comes to the ED, he's lethargic, confused, and he can't focus. He already has an IV when he comes in. He's nauseous with a fruity breath odor. So I think some of you already might know what this might be. If you have any ideas, you might drop it in the chat. And then we got his height and weight here. He's got sinus tack, lives alone. He's been quite sick over the last few days with nausea, and he's lost a lot of weight over the last few months. But she couldn't talk him into seeing the healthcare provider. And he recently had a bad bout of the flu a few months ago and hasn't bounced back. So he has a history of asthma and occasionally uses his steroid inhaler, but he doesn't have any other medical history. Okay, so remember, we're keeping a picture in our mind. So this is a 22-year-old. This is college senior. He was unresponsive, lethargic, confused, nauseous. His heart's beating fast. He's got this fruity breath odor, and I guess he's really skinny, and he's otherwise mostly healthy except for asthma. So keeping this picture in mind. Then when we actually do our physical exam, we confirm he's lethargic, he's tachycardic. At least his lungs sound clear, but we have these deep, rapid respirations, which it looks like a lot of you in the comments already recognize what that could mean. So you've already stepped ahead to our next step, which is analyzing cues. Well done. And then his skin is pale, cold, diaphoretic. We've got poor skin turgor, dry mucous membranes. So what could that mean? Those of you who knew it was DKA, in somebody with potentially DKA, what would poor skin turgor and dry mucous membranes mean? Let me know in the chat. And then we've got hypoactive bowel sounds, 1+ pulses. So remember, all these things, in addition to our mental picture from the note, we can also see that he's pale, cold, diaphoretic, and this poor turgor and dry mucous membranes. Doesn't look like anyone's commented yet to tell me what that might mean. Dehydration, Rick got it. Rick, you're cheating. You already passed your NCLEX. No, I'm just kidding. Thank you, Rick, for coming back. So we've got some signs of dehydration too, and then our vital signs we look at. Temperature is okay. We knew he was tachycardic, breathing fast. Blood pressure is low but not too low, and pulse ox is okay. So all right, we have this mental picture in our head. This college senior aged guy, dehydrated, sick, nauseous, lethargic, confused, breathing fast, and breath smells like fruit. All right, so from there, you want to think about what is most important, or all of these things, what requires the most immediate follow-up. NCLEX might specify how many things. Like in this item, we're being asked which four client findings would require immediate follow-up by the healthcare team. So keep in mind, we're always going to have a ton of things that are notable about our patient. We're going to have some pertinent positives, pertinent negatives, things that are missing that should be present, but not all of them are unexpected. And so you're going to have a lot of abnormal findings. Some of them are expected, some of them are unexpected. So we're looking for unexpected abnormals, and specifically abnormal findings that we could follow up on, that I could actually address and do something about. And so some things might be an unexpected abnormal, but not really anything I can address. So let's just take a look at these. And I haven't seen anybody has commented any guesses yet on these, so we'll just go through them one at a time. And whenever I've got which 4 or 3 or 2, or any time that the NCLEX specifies how many options you should choose, you're not going to lose points by picking one that's wrong. So for example, if I read this and I am certain of 3, you're not going to harm your score by guessing for the 4th, but you always want to shoot your shot and pick 4, okay? So let's read these one at a time, and I'm only going to pick those that I am certain are in the top 4, and then we'll see how many we wind up with at the end. So, okay, blood pressure. Now, the blood pressure is 106/68, and he's an adult, so this should be that normal blood pressure range, but it's not too low, right? Hypotension is technically a systolic under 90, so this is a borderline low blood pressure, but he's not hypotensive yet. Fruity breath odor, that's weird, right? Even if you don't know what that is or what it could mean, the fact that we've got this fruity odor, that's usually an indicator of some type of metabolic problem. But that is most likely what's causing an altered mental status in somebody this age, if it's not an obvious like drug overdose or anything like that. And so I'm going to hang on to that one as something that's definitely scary. Sinus tachycardia, pulse is 101. It's not a ventricular fibrillation or PVCs or anything that would be really scary. So I'm going to hang on to that one. It might be a problem, might not. Deep rapid breathing, yes. So that is also going to be connected to this fruity breath odor. We're seeing some type of potentially compensation by the respiratory system. And I'm seeing a lot of you guys are guessing 2, 4, 6, and 7. Melanie says 2, 4, 6, 7 for sure. So I like Melanie's confidence. Let's see. Weight and thin appearance. So that's an unexpected finding, right? This person has no reason to be so skinny, but it's also not something I could immediately follow up on. Even if I was super scared by this finding, there's nothing I can do right now to fix the fact that this patient lost weight over several months. This problem took several months to develop. I'm not going to fix it right now. Lethargic, confused, unable to focus. Yes, you guys know that neuro findings, that's pretty high up there in your ABCD. D is disability, is neuro findings. And a change in mental status can also represent a problem of breathing or circulation. If I'm not getting enough oxygen or blood flow to my brain, that can create these findings as well. So either way, I always want to prioritize abnormal neuro findings. And you guys said 7. Many of you did. So poor skin turgor, dry mucous membranes, yes. If you've got a patient with signs of dehydration, that is a circulation issue. That is an ABC issue. And we tend to kind of deprioritize skin assessment findings. So the NCLEX isn't going to give you something super obvious all the time, like low blood pressure and you can't feel their pulses. It's going to be a little bit more subtle. Like in this case, poor skin turgor, dry mucous membranes. Those are clues for dehydration. So I wound up here with 4, fruity breath odor and deep rapid breathing, which we think is likely some compensation for a metabolic problem. And then this lethargy, confusion, inability to focus, which could be one of many high priority problems, plus some findings of dehydration. So well done, you guys. And I want to remind you that on the new NCLEX, you really do have to know your content, especially for the case studies. You could kind of lean into testing strategies more in the older NCLEX, but with the next gen format, you have to understand what you're looking at, understand the disease process to be able to figure out what's most important and answer the rest of these questions in the format. And so if you guys need some help with your content, I would really highly recommend you to go check out our new NCLEX cheat sheets that we've been working on for the last few months at Bootcamp for you. And Courtney is going to drop a comment in the chat box that's going to let you go download some of those for free if you don't already have a Bootcamp subscription. But that will help brush up your content as well as give you some really high yield tips and mnemonics and things for stuff that we know is going to show up on the NCLEX for you. So check that out if you haven't already played with those. Then next, we're going to analyze these cues or figure out what could it mean, or they would ask that as what condition are they experiencing or at risk for experiencing, what could cause these findings, or how would I know if this or that complication was happening. So keep in mind here the big picture problem, all right? Keep this whole picture in mind and don't interpret any one thing in isolation. So let's take a look at how they want us to do that here. So, okay, we need to complete this after we get our lab results. So let's add to this mental picture our lab results. We've got a white blood cell count that's a little bit high, a normal hematocrit, sodium is a little bit low, potassium is a little bit high, chloride's a little high, BUN, so we've got kind of elevated labs all over the place. Our glucose is 411, or for those of you internationally, 22.8. And then we've got our blood gas. So we're going to look at this together because this question is asking us to answer that we should recognize that their blood gas demonstrates which imbalance that is likely caused by which cause. All right, so let us go through interpreting this blood gas together. And you guys said you're pretty confident in this, so we're going to move through it fairly quickly. I know people really like that mnemonic ROME, the respiratory opposite metabolic equal. I kind of like to think through it. We're going to talk about both ways. So let's first look at our pH, and our pH here is 7.12. Now that is low. So if I'm interpreting this, is my pH low or high? And a low pH is acidosis, right? So we can already get this far. We can eliminate these, and we're looking for the cause of this acidosis. And Yenny, Audra Marie, Gary, Harpreet, you guys are guessing metabolic, well, not guessing. I think you're making a very educated guess at metabolic acidosis. So let's look at that. If we're looking for respiratory opposite, metabolic equal, let's see what our secondary imbalance is. So this just tells us about our oxygenation, which we're not really mainly concerned with right now. Our CO2 is normal at 38, and our bicarb is low at 12. So our pH is low and our bicarb is low. So those move in the same direction, or the equal direction. So in that mnemonic Rome, that suggests a metabolic imbalance. And sure enough, if I have a low bicarb, metabolic acidosis. So I'm going to agree with you guys, and we'll look at this one. Now, is it caused by metabolic acidosis, diabetic ketoacidosis, DKA, due to DKA? All right, somebody guessed respiratory alkalosis, and I want to point out this is an interesting thing with ABGs. So if I had Kussmaul respirations, that's that rapid, deep breathing. If that was my main problem, say somebody's just hyperventilating and they're breathing too fast, what kind of imbalance would that cause? That would blow off a lot of extra CO2, right? So we would see a low CO2, and that would create a respiratory alkalosis. So that isn't the cause of the problem here, and that is actually a form of compensation. So because we have a metabolic acidosis, something is broken with our metabolic system, our patient's kidneys and other metabolic processes aren't able to regulate their level of pH and bicarb, and so their lungs have to kick in to try and help. And so they're going to start breathing faster to try and get off all this CO2, which is considered acidic, to kind of correct and compensate. Yes, Rick says Kussmaul's is a compensatory response, not a cause. Exactly. So that is not the trick. It's not really a trick question. It's, do you understand what's causing the problem here and what's helping to fix it? And so you guys are right. This is caused by diabetic ketoacidosis. And if it was hyperglycemic hyperosmolar syndrome, what would the pH say? The ABG would tell us that it's normal, right? Because that's the difference between the DKA, which is the type 1 diabetic acute complication, and HHS, which is primarily the type 2 diabetic complication, because you have enough circulating insulin to prevent acidosis. So you don't have ketones, you don't have acidosis, your ABG is normal. So well done, good job you guys. I guess I should check our answer. Yes. Okay, good. So yeah, only 70% of our users in the bank got this right. So you guys you weren't kidding. You guys know your ABGs. Awesome job. And so remember, if you don't remember DKA, the way this works is we don't have any insulin being produced in DKA. That means you have glucose in your bloodstream, but it can't get into the cells, so it builds up in the blood. So it's low in the cells and really high in the bloodstream. So your body can't use it for fuel and starts metabolizing fat and protein really from your organs and tissues instead. So that has an acidic byproduct called ketone bodies that build up in your blood, and we have all this fat wasting, muscle wasting. That's why he looks so skinny, is because he's probably been surviving off of his own organs and tissues for a couple of months now. So we're going to see acidosis, and then from that really high glucose level in the bloodstream, that creates something called osmotic diuresis, where just because there's so many particles of sugar in the blood, it starts pulling water out into the urine, and so then they get dehydrated. So we're going to see these two things with DKA, acidosis and dehydration. And I think you guys see those findings in this patient scenario. So next, we're going to prioritize hypotheses, or figure out, where do I start? And they might ask, what is the client most likely experiencing, at risk for, or what should I do first? And when I'm trying to prioritize actions, patients, or anything, I kind of like to ask myself this question: if I can only do one thing and walk away, or see one patient and ignore the rest, who is it, or what action am I going to do? And so let's figure out how they want us to prioritize hypotheses here. So now in this case, we're being asked, the nurse should first address the client's nausea, leukocytosis, which is the high white blood cell count, hyperglycemia, or fluid volume deficit, followed by which of those? So we need to pick our top two. Which one do we want to address first? Which one do we want to address second? And then after we start to treat it, what do we expect their potassium level to do? To increase, decrease, or stay the same? Do you guys remember, for prioritization, what do we want to prioritize for this patient? Remember, we've got two big things going on, and that is, we have our DKA, which is acidosis, and dehydration. And the source of all of these is that we can't really get glucose into the cells. And you guys are, fluid deficit, fluid volume deficit. And I agree, because that, although it's not the primary problem here, it is the priority problem. That is a issue of circulation. It kind of doesn't matter what my blood sugar is if I don't have enough circulating blood volume to perfuse my brain, my kidneys, my tissues. That is an emergency. So yes, we are going to first address their fluid volume deficit. And then you guys said hyperglycemia first. And I agree, hyperglycemia, because remember, that is kind of the root of what's causing this dehydration problem. And how would I fix it? How would I address, you guys said fluids, to give fluids. How would I address their hyperglycemia? There's a medication I'm going to give. I got 2 meds I'm going to give to correct this. First, fluids, like you guys said, to address the fluid volume deficit. And then, Audrey Marie says the client's dehydrated. The nurse should give fluids for the deficit. Hope's getting ahead. Cadena says give bolus of fluid with an insulin drip. Yes, exactly. So we are going to give continuous IV insulin for DKA. And when we give insulin, what is the potassium going to do? And Hope said the K will go lower. eReview says, if I had said hyperglycemia first, then fluid volume deficit, would I get it wrong? Yes. The idea is that you're prioritizing in this step. In step 3, you are picking, what do I do first and second? And so if you'd said hyperglycemia followed by their fluid deficit, then you would be delaying addressing the circulation issue, and that'd be putting your patient at risk. And everyone is saying decrease the potassium, and that is right. And that's really, really important to remember. So we got this correct. That's really important to remember, because low potassium can cause those dangerous dysrhythmias. So basically, insulin is responsible not only for carrying glucose into the cells, but also carrying potassium into the cells. And so when you've got really, really high hydrogen ions or acidic blood, your cells try to balance this by just pulling in, kind of collecting and storing away as many hydrogen ions as they can to pull them out of the bloodstream and try to kind of buffer that really, really low pH. And then we give insulin, and then the potassium is going to shift into the cells. So that's why we tend to see high potassium before we treat in DKA and then low potassium afterward, because we've pushed it into the cells. So that's something important to anticipate. Very good. All right, so next we're gonna generate solutions in question 4. Figure out, what can I do? What's indicated or not indicated? What's gonna address the priority problem or worsen that problem? And remember, this depends on your understanding of the content, because I would treat dehydration, or I would treat impaired perfusion related to dehydration with IV fluids. But if I tried to treat impaired perfusion from heart failure with IV fluids, I would overload my patient. So you really have to understand why you're doing each thing and seeing each thing. So let's look at that here. In question 4, we've given a bolus of IV fluids, transferring to the ICU. Now for each of these potential orders, click to specify whether the order is anticipated or not anticipated in the care of the client. And so let's take these one at a time and obtain blood cultures. So we get blood cultures when we're worried about what problem? When we're trying to diagnose a very specific problem. And it's another problem that can cause signs of low perfusion if it ends in shock. If we're culturing anything, it's to see if there are organisms in it, right? So if I'm collecting blood cultures, it's because I'm looking to see if this patient has sepsis. And Oman says, no, I don't need to know. 1, it's not anticipated. Yes, you're correct. We don't want to do wasteful diagnostic studies. This would waste time. We don't have any reason to give this patient blood cultures. We don't have a fever. And then the only sign of infection that we might have is this high white blood cell count, but that can happen with inflammation too. And we've got obvious inflammation in this patient. Good. Monitor mental status hourly. Yes, right? We've got an abnormal mental status. We're told this patient is lethargic, confused, and when we're giving IV fluids, we can cause some rapid shifts in fluid shifts, including with the brain. So when you're treating DKA, you're watching for signs of cerebral edema. So they come in and they're lethargic, and our treatment is going to be putting them at risk for cerebral edema. So it's very important to monitor their mental status. Now, am I going to feed this patient right now? Do I want to initiate a carb-controlled diet? And you guys said 2 is anticipated. You guys are excited. I love all caps from Peter and Cadena. All right, so remember, if I feed this patient, not only is he nauseous, but I'm trying to really tightly control his blood sugar. So yes, you guys are correct to say no. I might eventually do this, but this patient is not ready to eat. That's going to set us back by raising his blood sugar and making him more nauseous. Continuous cardiac monitoring. Yes, we talked about how our treatment is going to be lowering the potassium level. The potassium level was already elevated when he came in. And so anybody who has an electrolyte imbalance with potassium, you want to make sure that they are on the cardiac monitor. So good job. Monitor INO. Yes, we've got a dehydrated patient with poor skin turgor, likely low urine output. We've got tachycardia. So we've got signs of dehydration and we're giving an IV fluid bolus. So our fluid balance is a major thing that we're addressing here, and we want to do this. Monitor the capillary blood glucose hourly. Yes, we want to check the blood sugar every hour and make sure not only that we're giving them enough insulin, but almost more importantly, we don't want to give them too much insulin and drop their blood sugar. So that's the other big thing we're monitoring when we're treating DKA. It's their mental status and obviously their INO and blood sugar. Those are our kind of big three. So that's correct. Do I want to collect the serum potassium every 2 hours? Yes, just like we're worried about the glucose going too low, we're worried about the potassium going too low as we give insulin to push it into the cells. So we're watching that and making sure that we're not causing hypokalemia. Then a continuous IV insulin infusion pump, yes. So we're going to give continuous insulin. You never hang insulin, heparin, potassium, or any other high-risk drug to gravity. These always go on an electronic infusion pump. So this is correct as well. Then continue IV normal saline at 500 mils an hour for the next 2 hours. Yes, this patient needs a lot of fluids. They become very dehydrated from this. So we've given an IV fluid bolus and we need to continue giving IV fluids. So, all right, this is a lot of work. This patient needs a lot of things, and this is a very critically ill patient with circulation and metabolic issues. So we don't need to worry about infection. We need to keep them in PO. And then while we're giving IV fluids and insulin, we're watching their mental status, their heart rhythm, their INO, glucose, and potassium. So this is a big monitoring patient. And we're correct. So next, we're going to take action or actually do the thing. They want to know, what will you do? Should you do it? How should you do it? And in this case, you're an experienced nurse now. So you've been a nurse for a little while, and you're supervising a new graduate nurse who's preparing an IV insulin infusion. So high risk med. I already told you guys that that's not an option here. So we already told you that we have to give it on a pump. That's one of the things we do to keep them safe. But which action by the new grad nurse would cause us to intervene? So we are looking for something they're doing that is unsafe, that makes us want to stop them and correct them. All right, so do we want them to verify the concentration of regular insulin in the IV bag? Yes, and in fact, we need to do that together. Most facilities that you guys will work at as a nurse, when you're giving a high-risk medication, it requires like a 2-nurse sign-off. So 2 people actually look at it and go through your 10 medication rights together. So that's correct. I'm going to cross this one out because I don't need to intervene for that. Then, am I going to verify that 50% dextrose is available to reverse hypoglycemia? Yes, if I accidentally give them too much insulin and drop their blood sugar, now their cells in their brain aren't getting enough glucose. So you need to treat that with that 50% dextrose, which if you guys have ever given it, it's like syrup in a syringe and it's really thick to push. So yep, 50% dextrose, have it just in case. Then waiting for a second nurse to verify the dose before starting the infusion. Yes, that's a very important safety step to have that second line of defense looking behind you. Then finally, request an order to add dextrose to the IV fluids once glucose is under 100. So we do, remember, worry about creating hypoglycemia, giving too much insulin, and it might seem counterproductive to add dextrose or add more sugar to somebody who already has a super high blood sugar, but hypoglycemia is more dangerous than hyperglycemia. And Oman is right. He said that's it's answer 4 because 100 is low. Rick says yes, right. We want to be a lot more cautious than this. We want to make sure that before it gets below 100, we're adding some dextrose to the fluid so that we aren't dropping their blood sugar too fast. And we're only checking their blood sugar every hour, right? So we're not going to know that there's a problem until maybe an hour later. So this would cause me to intervene. I would say, no, we need to do this once the glucose falls under 250. So as soon as their sugar gets under 250, we change their IV fluids and just continue to slowly taper. Well done, you guys. All right, then I'm evaluating the outcomes, figuring out did it help or was it effective or what signs would indicate a complication. All right, so now we've got this update. We're going to read it again here. So this is after, looks like overnight. So they were admitted around 5 p.m. Now it's around 3 a.m. and we've got some new complaints and we're asked, click to highlight the findings in the nurse's notes that would indicate the client is not progressing as expected. So we are looking for unexpected findings that aren't in line with a normal recovery course. Complains of leg cramps and weakness. Based on the things 2 questions ago that we talked about complications we're worried about, because we're worried when we're treating DKA that we're going to see hypoglycemia, cerebral edema, maybe hypokalemia, possibly even fluid overload if we get fluid too fast. So leg cramps and weakness, does that fit with one of those complications that we've been monitoring for? Let's go on to the next one. We've got vomited 50 mils of clear fluid. Potassium level is 2.5. Yes. Hypokalemia. Bean C says hypokalemia. Ishia, you guys know it. Right. So we have accidentally given our patient hypokalemia through the treatment. It happens. That's okay because you're an experienced nurse, remember, and you recognize it. So potassium regulates your muscle contractions. So that's going to show up as leg cramps. You might have abdominal distension, hypoactive bowel sounds, and your heart is a muscle too. So you're going to see irregularities in the heart rhythm or the strength of the contraction. And so this creates big problems. But yes, leg cramps and weakness, that tells me hypokalemia, vomiting along with this abdominal distension, hypoactive bowel sounds. Our glucose is 225. And when they came in, it was 411, then 325, now 225. I think that's normal. I honestly can't remember, you guys, if this was a correct or an incorrect option, but from the look of this, we've gone down from 411 to 325. There's nothing I need to do about this. That's expected. At this point, I would just switch their IV fluids, but this is an expected thing. I expect to see their glucose going down, not too low. I expected to see their potassium going down, but not this low. So I'm going to leave this unselected. Then my cardiac monitor shows ST depression, flattened T waves, prominent U waves, and occasional PVCs. So that heart is getting irritable from that low potassium level. Then our heart rate's irregular. Yep, that's those PVCs. So we've got heart rate irregularities. Our pulse is 95, which is improved, right? From 101, 92, 95. So pulse is improving. Pulse ox is normal. Going to leave that unselected. Then my extremities are cool and my peripheral pulses are weak, which is not normal, right? We want warm extremities, strong pulses. And we're correct. So these findings all indicate hypokalemia. And in case you guys don't remember, hyperkalemia, remember the T, when your potassium peaks, the T wave peaks too. So we see that really tall T wave is classic for hyperkalemia, and it's sort of the opposite for hypokalemia. So it dips in and stretches out and is prolonged. So we've got signs of hypokalemia, and what would you guys do to treat it? Yeah, we would need to give potassium, right? We actually need to replace the potassium and continue to monitor that. Great. So guys, that's it. You guys did so well. I'm actually really, really impressed. And I hope that was helpful. Please go check out our cheat sheets. Go check out some of our free case studies. If you guys don't already follow us on our social media, please go ahead and do it. And actually on our Instagram and TikTok, we've started putting out these little previews from our cheat sheets where we show you the top 2 or 3 testable things about different topics. So that's a lot of fun and really helpful if you guys haven't already followed us there. And also join our Facebook group. You can kind of invite your friends to this as well, so you guys can have a little bit of community and support there while you guys are all studying for the NCLEX together, have questions about the platform. And check your comments, check our comment section, because Courtney is going to give you guys a discount code for 10% off of a bootcamp subscription if you'd like. And I was so happy to have you guys join today. You're so, so welcome, everyone. Thank you for showing up. Follow us. And Hope says, give K-Riders. Exactly. Hope, I can tell you're already working in the hospital. So, all right. Great job, you guys. Thanks again. And y'all have a good rest of your day and hopefully enjoy some spring weather wherever you are.